Синьо онкологи, медичні фізики, радіаційні терапевтичні технологи. Слава Україні! Дякуємо, що приєдналися до Modern Brachytherapy course with ABS experts for Ukraine. Help Ukraine Group, in collaboration with American Brachytherapy Society with SweetCare support, is excited to present the 8th lecture in this course. And the topic of today's lecture is brain LDR brachytherapy. Dr. Serhiy Brovchuk will co-moderate this lecture with me, and he will introduce our two fantastic speakers.
Thank you very much, Natalia. So our first speaker is Dr. Jonathan Weiss. He is a board-certified radiation oncologist at Miami Cancer Institute. Dr. Weiss specializes in treating thoracic central neural system and gynecological cancer with expertise including advanced technologies such as gamma knife radiosurgery and interstitial brachytherapy. Prior to joining Miami Cancer Institute in 2022, he was a clinical instructor in the radiation oncology department at the University of California, Los Angeles. Dr. Weiss also served as a chief resident at Princess Margaret and Odette Cancer Centers, the premier cancer programs in Canada, actually. So before beginning his medical training, he worked as a cancer research investigating DNA repair in organisms that were resistant to radiation. His research has been presented at national and international scientific conferences. Our second speaker today is Dr. Vibha Chaswal. She is an ABR certified clinical medical physicist with more than 15 years of experience in radiation oncology, specializing in advanced treatment techniques, commissioning, quality assurance, patient safety, and the mentorship for medical physics residents and medical students. She currently serves as a senior medical physicist at the Miami Cancer Institute, Baptist Health, South Florida, where she also chairs a continuous quality improvement committee. In the leadership role, she drives initiatives that enhance workflow efficiency, promote clinical and standardizations, strengthens radiation safety practices. As the education director of medical physics residency program, she plays an active role in shaping and mentoring the next generation of medical physicists. A strong advocate for proactive error management, Dr. Chaswal is a member of National Work Group on Prevention Errors in Radiation Oncology. She is recognized a leader in promoting global good catches culture, and she has organized and participated in international sessions on the topic of APM, ABS, AMP, IOMP conferences and integrates these principles into her clinical practice, so to enhance patient safety and team learning. Dr. Chaswal completed her PhD and Master in Medical Physics at the University of Wisconsin-Madison and CAPEP accredited residency at the University of Iowa. Her clinical accomplishments include commissioning the first Geneva HDR applicator in the US and leading major technology transitions such as from variant to Elekta HDR system and Pinnacle to TPS. Her expertise includes SBRT, SRS, MRI-guided HDR, and null brachytherapy techniques like gamma tail and alpha data RT. She is a recipient of the prestigious Judith Stitt Best Paper Award in Brachytherapy for her pioneering work in directional brachytherapy and holds US patent for a novel treatment planning technique. With the multiple peer-reviewed publications and ongoing national leadership, Dr. Chaswal continues to elevate standards in clinical physics and patient-centered care. Thank you so much for preparing the lectures today. It is an honor for Ukrainian community to have you both as a speakers with us, and we are looking forward to your lecture on brain LDR brachytherapy today. So the podium is yours.
Wow, thank you so much for the introduction, and thank you, Saria and Natalia, for inviting us to speak to this fantastic group. So I'm going to share the screen. Let me know if there's any issues, otherwise I'll proceed. So as mentioned, our topic today is going to be all about brain low-dose rate brachytherapy. And so we have no relevant disclosures, but just to be totally upfront, this will be primarily about gamma tile, since that's the technique that we're using at Miami Cancer Institute. Although we will go through the history of other techniques and some other ways that this can be done. So in terms of the indications first, so brain metastases is the major indication. Whether they're suitable for external beam or not can be somewhat debatable, and the scope of this topic is really about the LDR rather than all of the management of brain metastases. But basically, any recurrent central nervous system cancer, in theory, could be reirradiated with brachytherapy. As a somewhat emerging role, the potential for upfront management of either metastases or primary cancers. But generally, it's small, well-defined lesions that are less than 3 centimeters, given the nature of the way that these are implanted, and can be used again from the metastatic or primary glioma or meningioma pathologies. In terms of just a very broad overview of metastases, so these are obviously secondary tumors, as you know, that can spread to the body from the primary site, which is a significant challenge and a major cause of morbidity and mortality in cancer patients. And we have challenges to control the brain disease while also preserving neurological and cognitive functions. And so a lot of work in the radiation oncology world, as you know, has been ways to essentially preserve cognition while still aggressively treating cancer. And so these brain metastases can occur in up to about 1/4 of all cancer patients. In the United States, that's up to about 200,000 people per year. Brachytherapy, now that this is, I think, well into the lecture series, is, as you know, the direct placement of these sources directly or near tumors or resection cavities, with the overall benefit of being able to deliver high dose radiation and minimizing damage to the adjacent tissues. So the evolution of brain metastasis management in general has evolved from essentially supportive care into what was first done, which is, as you know, the whole brain radiation therapy. So this is still standard in many situations, as you know, but certainly has issues with cognitive impairment. And so more targeted techniques, both from the stereotactic radiosurgery world as well as hippocampal avoidance, whole brain radiation, are both fairly widely available techniques in many places now to reduce those cognitive side effects. But we'll speak obviously more today about one other option, which is the brachytherapy, and ways that this could be used sort of in lieu of stereotactic radiosurgery. In terms of the overall literature on this topic, wanting to be a little more broad than just the technique we're using here. So here's a fairly recent systematic review published last summer. And really there was 34 trials looking at brain LDR, brain brachytherapy, in over 1,000 patients treated with this technique. And so things that they were looking at is what were the techniques used, what are the isotopes used, and the patient outcomes. And so most of these trials from United States, and the majority of the rest from Germany. And so the main cancers being lung and breast and melanoma. So the radioactive seed implants has been done with several different isotopes, so iodine 125, palladium 103, and cesium 131. And the first use of this actually dates back to 1981 in that article there. And so essentially the advantage here is, and sort of a picture on the left, although we'll look at more pictures later to describe what you're looking at in more detail, showing very high local control, approaching the 95% range, and survival, of course, depending on multiple factors, biologically, extracranially as well, obviously. So in terms of complications and toxicities, so this is a complex surgical procedure. It certainly depends on both the expertise of the radiation oncologist, the medical physicist, and the surgeon, because this treatment planning involves a significant amount of work. And so Dr. Chaswal later on will speak more about that. There is some risk about seed migration that has a low incidence, especially now these are coming sort of in these tiles. But in the original forms, without this sort of more rigid tile, the seeds could migrate. And of course, you can worry about hot spots in contact with tissue, especially when you're worried about eloquent areas of the brain or in re-irradiation. And so there is certainly a radiation necrosis risk. So we'll go into a little bit more detail. So this is one of the other systems that we're not using here, but called Gliosight. So this was using iodine. So it's an FDA-approved balloon catheter device. So this sort of balloon idea, you may recall from other lectures, has been used in other types of brachytherapy, including breast cancer, for example. But essentially this gliosite was filled with an aqueous form of iodine to deliver radiation to a tumor bed. And local control rates were fairly good. The main issue with this technique is that in some of the trials, the necrosis rate was up to 23%. So compared to gamma knife or a linear accelerator based stereotactic technique, this is significantly higher. And of course, with any surgical manipulation, there's a risk of infection, meningitis, edema, or other post-surgical complications. And so these tiles, so rather than using, the company name, you can call them bioresorbable collagen tiles, cesium-131. And so here are some details about them. The half-life is fairly short at about 10 days. So most of the dose is gone within a month or so. Because they're in this tile sort of form, they have a uniform, accurate dose delivery that's more homogeneous than other forms that may be related to a central channel with a hotspot. And so this has lower necrosis rates compared to the gliosite system. And ideally, if people can recover from this treatment, and then they can resume on other treatments sooner, other systemic therapies. So here's a picture, and again, we'll see more a little bit later, but looking from A, where you have the resection of the tumor, B, layering it with the tiles, C, placement of some Surgicel, just like to prevent, bleeding and whatnot on top of it, and then some glue to keep it in place. So in terms of treatment efficacy, this is from the review articles and some of the trials that it was based from, but local control rates varying between techniques. And obviously these aren't randomized control data. And so there's different cohorts, of course, have some random variation, but all of them are pretty good in terms of local control. I wouldn't say that there's one that's a complete standout, basically. I mean, even resection and whole brain radiation therapy has good local control. But I think one of the more important aspects is the necrosis rate. And so the gamma tile technique has a similar necrosis rate to SRS and radiation necrosis for the gamma tile, sorry, and gamma knife or LINAC-based SRS. So in terms of clinical outcomes, this is from specifically to like the gamma tile studies. So in the initial trial, there's really no instances of radiation necrosis with really good local control, 100% freedom from local progression. With the recurrent patients, over 80% had a local freedom from progression with one case of necrosis, and in the large brain metastases, surprisingly, actually no cases of radiation necrosis, and also excellent local control. And so the resection cavity is something that is something worth speaking about. So once they remove the tumor, there can be changes essentially. And so that cavity can shrink 30% in the first few days after surgery. And so the radiation distribution and the seed placement can be impacted by that. So this is something that was, I think, part of the thought of maybe why the gliosite had these necrosis risks, because the studies show that there's less cavity shrinkage when you're implanting these sort of more rigid tiles. And so I think that may be one reason why this technique is sort of become more preferred, at least for us. In terms of a workflow, which which we'll speak a little bit more about in the second section. Of course, you need a patient. With any stereotactic radiosurgery, you need updated MRIs to help plan. For us, when we're doing like even not a gamma tile, but like a regular gamma knife or linear accelerator based, we really actually want these to be within a couple days of the treatment, because there have been some reports that the actual volume of these metastases can change within, a few days period. So if you're using a PTD or something like that, then sure, fair enough. But if you're not using one, like in these techniques or in Gamma Knife, you really want that to be very an up-to-date image. These images are uploaded, contours are created. I think that's fairly self-explanatory for radiation oncologists. And then the sort of black box is the medical physicist expertise, which we'll get into a little bit later in terms of dose distribution, tile estimation. And so Vibha's, Dr. Chaswal has published on this topic about how exactly we do this and order the tiles and all that. So then the surgery is performed with intraoperative pathology. And so this is really, I think, the main benefit of this technique is that you can confirm that this isn't viable tumor cells and not just necrosis, because sometimes there can be some uncertainty whether after an original radiation treatment, whether it's radiation necrosis or in fact tumor. So a surgical management can be diagnostic and treatable in either situation, basically. So then after tile implantation and you have to close and finish the surgery, a dosimetric analysis is performed, and then you can do post-op calculations in the treatment planning system. So this is really one trial looking at cognitive function outcomes. And so they showed in this trial, Pham et al., that there were significant benefit in cognitive function out the 4 to 6 months compared to other radiation techniques. Although this is really a very small trial, and I think it's far too early to draw conclusions. There can be, of course, selection bias and such, but something interesting to think about. In terms of brain metastases, in general, though, as we mentioned, the cavity changes between planning and treatment, and so delaying treatment can result in worse outcomes, even death. And previous radiation can limit options. And so for glioblastoma, really, as any CNS radiation oncologist is familiar with, even when you treat them according to the STU protocol or whichever protocol, and give it the maximum dose you can, local recurrence is really the rule rather than the exception. And most are recurring either inside or within a few centimeters of the resection cavity. There's also some patients that have rapid progression, either following radiation or even before they start radiation, with poor survival. And so there have been some reports of using this with a glioblastoma. And so, of course, this is a very well-selected group. This is a report from China where, at 1 year, over 80% had local control, with a 25-month median overall survival. So in these very carefully selected patients that probably had these, less than 3 centimeter focal areas of progression, pretty good outcomes were achievable. And meningioma, just to round off these histologies, these can be very challenging because the fields can be quite irregular in shape. But in the gamma tile cohorts that have been used for this, almost 90% progression-free at 18 months, 10% necrosis. And so that's, one report of it being used for meningioma. Here's just some outcomes with the brain metastases. So sort of with the recurrent and with the gamma tile, again, these aren't randomized control, but compared to the rest, it certainly is doing very well in terms of local control. Again, similar necrosis. There's ongoing trials, and so anybody interested in reading more, here are some of the ongoing trials, Rhodes, Pathways, and Gestalt. So looking at some of these other combinations. So the first one being for brain metastases, the second and third being for recurrent or upfront glioblastoma, respectively. And so just to sort of start ending off this section, there's certainly been increased adoption across academic centers, hospitals in the United States, over 1,000 patients treated at over 30 centers. So there is a registry called the START registry. And so that's something we participate in. And so hopefully with more time, there will be more expanded indications and increased confidence and, reduced side effects. And so this, just to show one example from a publication from our center, just for those interested in seeing sort of some differences in the isodose distribution between different technologies. So here you can see the gamethyl. So obviously these are all conformal, but this has, of course, this hotspot, this red isodose line, which is ultra hot. And then in the others, of course, you still have this similar conformality, but there's some differences in terms of the hotspots. So this is IMBT in the modulated proton therapy has a lower, more homogeneous dose, and then gamma knife, cyber knife, fairly similar. And the hottest, being with the gamethyl. And so here's sort of another image of some of these isodose lines. How much some of this matters in terms of that central hotspot compared, between the gamethyl, gamma knife, cyber knife, linear accelerator based in that order of sort of highest hotspot to lowest hotspot, of course, is debatable, and I think more remains to be seen on that. And then just briefly in terms of the actual prescriptions, so the way that the gamethyl is prescribed, and this will be, again, a little more in the physics section, but it's usually 60 gray prescribed to 5 millimeters. That might be relevant for maybe a multiple choice question. Whereas for fractionated SRT, stereotactic radiation therapy, it's usually 30 gray and 5 fractions, with or without a CTV, PTV, depending on the technique used, different energies based on whether it's coplanar or in gamma knife using a shot techniques, those algorithms. So this is for those that want to refer to later, some of the differences within the technology. And sort of when you look at the actual BEDs, so the biological effective dose, you can see the difference between a similar treatment looking at the different technologies. So 90 with the gamethyl down to about 50 with the protons, with gamma knife and cyber knife being in the middle. And this is a similar sort of dosimetric analysis looking at the volume getting 24 gray, 10 gray, 8 gray respectively between these techniques, for anyone who is wanting to review later all of those different numbers. So here's our summary. So for gamethyl, this approach has a good and higher BED compared to others techniques. The V24, which in many trials is linked to radiation necrosis, is actually higher because of the spillage dose compared to the gamethyl, even though the hotspot would be higher in the gamethyl. And so this is definitely a good treatment option. In terms of future directions, of course, patient selection, more investigation into long-term effects, more comparative studies, that's really, I think, lacking, and standardization between the 30-ish centers using this technique would all be useful things. So with that being said, I will do the first multiple choice question. So we'll let that simmer for a few minutes.
Do you mind reading the question?
Sure.
It's
So
also
LDR intracranial brachytherapy is most appropriately indicated in which of the following situations? So A, diffuse infiltrative gliomatosis, B, multifocal leptomeningeal metastases, C, recurrent glioblastoma or brain met with prior radiation, or a D, large unresectable midline glioma. And so
yeah, we'll wait until approximately 80% answer. So currently there is 63% answering. That's how we take attendance as well. So they're encouraged to answer questions. Excellent. So we have 83% answering. I'm ending the poll, sharing result. So majority, 83% answered C, recurrent glioblastoma brain met with prior radiation.
Yeah, so I think out of all the options, that was the most appropriate options. So really, I think what we're trying to get at is that it has to be relatively small and it has to be sort of focal. So A and B are not focal diseases, and then D, if it's large and resectable, it should be resected first. You may want to do it in the resection cavity, for example, but the standard of care for a primary glioma is resection first. So that's the first question. And I think let me, and then here's question two. Um, I don't know. Okay. So, which of the following is the most common clinically significant toxicity associated with low dose rate brain brachytherapy? So, A, alopecia, so baldness and scalp dermatitis. B, radiation necrosis or peritumoral edema. C, bone marrow suppression. Or D, cranial nerve palsy due to distant scatter radiation.
Still waiting for your responses. So we have 66%, a little bit more, please. Yeah, 80% answered. I'm ending the poll, sharing results. So majority of you answered B, radiation necrosis and peritumoral edema. 74% and picked that answer.
Yeah, so that's good. Not necessarily wrong. So after the surgery, you may have sort of a patch of alopecia from the chemotherapy, but it's not really the brachytherapy causing that. B is certainly correct. While it's not ultra common, it's out of the options, I think the best option. There shouldn't really be bone marrow suppression. And then D, cranial nerve palsy. Depending on the area, it's possible, but I think those would be areas that you would be um, not doing this technique, and it wouldn't really be due to distance scatter radiation. So thanks everyone for listening and participating. And I will briefly stop sharing the slide so that Dr. Chaswal can share from her office.
Thank you so much, Yoni. That's excellent presentation.
Thank you, Dr. Weiss. I'm gonna share the screen now. Are you able to see the right screen?
Yeah, looks great.
Okay, so this brings us to part 2 of our presentation, which is more of radiation physics considerations. And so I thought I'll start with some sort of a chronological journey. And looking at this table, I'm pretty sure all of you can recognize that this is created with help of AI because we have the tool now. But I did try to verify the information, and for the most part, it seemed correct. Though when we are using AI to generate our tables, it is extremely important to verify the information. The glia site was incorrectly labeled as iridium 192 in this table, which is a correction that I did, and I taught AI and I told it to rethink, like, are you sure glia site is iridium 192? Historically, lots of radioisotopes have been used for brachytherapy in the brain. And the main thing that I wanted to point out from this table is that starting from 1930s to now, what have been the trend in the evolution of radioisotopes and their use in brain brachytherapy. So from very high energy isotopes in the MeV range to now we are into low keV ranges and gamma beta emitters both. Half-life, we're using shorter half-life radionuclides, which deliver dose faster. And from manual and interstitial techniques to stereotactic techniques, which we still use, we are now progressing into intraoperative precision when it comes to LDR brachytherapy. In terms of applicators, moving from needles, catheters, to balloons and now tiles, which is much easier to implant as compared to all 3 of these applicators. And in terms of toxicity, I don't think I can make this as a huge, I would say, conclusion statement here, but the journey has been from severe necrosis because the seeds were getting implanted right in the tissue to mild edema or low necrosis, neurotoxicity. Now that's been the journey. And in terms of precision, of course, now there's a major improvement in dosimetry and localization of these implants. So the three main radioisotopes which have proven the test of time are iodine, palladium, and cesium. Cesium even more so in the last 10 years, I would say actually last 7 years, has become the isotope of choice because of shorter half-life and similar energy. All the three isotopes are pretty much similar energy in their profile. The half-life differs. And in terms of time to deliver 99% of the dose, cesium delivers this 99% of the dose in almost 2 months. And similarly, the 90% of the dose is pretty much half of this value. So that's kind of like a rule of thumb. So 90% of the dose is delivered in almost a month. So quite a effective radioisotope. Now, in terms of brain mets, now this study got done by the same company who developed the collagen tiles or the gamma tile. The most important part here to understand is the rate of local recurrence strongly correlates with the time between surgery and the implant or when the radiation starts getting given. So in terms of the SRS delivery timeline, starting to give radiation after surgery within 4 weeks, you can see that the local recurrence is really low, like 2.3% versus if the radiation is given after 8 weeks, the rate of local recurrence is almost 50%. That's a pretty strong difference right there. So what this indicates is that LDR brachytherapy works because when the resection happens, you don't have the delay between the radiation. It's giving right there and then, and you don't have to wait even 4 weeks for that. In general, intracranial LDR brachytherapy advantage over external beam. So ICBT offers an adjuvant radiation therapy option, which is going to thrive. It improves outcomes, and Yoni showed so many slides about that. The advantage is that radiation therapy begins right at the time of tumor excision. It's usually a permanent implant, can be a temporary implant also with tumor excision. Like once the tumor is excised, you implant the sources once and done. An ablative tumor dose with very sharp dose fall off is obviously going to be a brachytherapy advantage. And salvage RT is made possible in recurrent tumor settings. So in terms of traditional brachytherapy, what I mean here is more like seeds and sutures where the seeds are implanted right in the tumor. So even though it's still a very viable option to do brachytherapy, but it still has high necrosis and hot spots right at the source or the tissue interface. Uniform spacing of loosely placed seeds or stranded seeds is usually very challenging because these seeds tend to cluster. Once the swelling and the shrinkage of cavity that Yoni was talking about, that happens. It's difficult to access the implant and for the irregularly shaped cavities. It's a highly complex procedure. It's a time-consuming implant. It takes time to either implant seed by seed or make those seeds, stranded seeds. It's a time-consuming implant with respect to what we'll talk just in the future slides. And the possibility of increased personal exposure is there. It's the maintenance of seeds and strands placement and their accuracy in the tissue. The treatment planning is very complex, and putting your seed right at the place where you've planned in your treatment plan is way more complex. and there's an increased rate of treatment toxicity. So in terms of traditional brachytherapy, before 2019, which is when GammaTile was FDA approved, the number of centers doing intracranial brachytherapy in the US was just 10. And then this collagen bioreabsorbable tiles, they come as a viable option, which is very easy to implant and takes away the complexity of the treatment plan and suturing and implanting seeds in there. So that becomes a game changer, and you can see that there's a very strong adoption of more centers now being able to offer intracranial brachytherapy to their patients in the US. And it's a superbly dramatic increase. So much so that we can say that this has changed the landscape of ICBT in the US for sure. And the centers here, these are not just the academic big centers. There are community centers with very little resources, and access to a neurosurgeon still being able to do intracranial brachytherapy now. So I try to convert the same. What is the advantage that got offered by this GammaTile option? So the hotspots were tolerable now. Uniform spacing of loose or not loose or stranded sources. I should have changed that. So uniform spacing of the seeds was made possible because of the design of the tiles. It's easy to access and implant in even irregularly shaped cavities because the tiles can be cut and implanted. The implant timing is super fast. Placing those tiles once the surgery is done takes from 1.5 minutes to at the maximum 4 minutes. And personal exposure is inconsequential because seeds do not fall out of the tiles. It's not a liquid source. These are not small seeds which can fall away from a forceps or anything. And seed placement accuracy is pretty much maintained in the tissue until the tiles actually get fully absorbed, which is the time during which the dose is actually delivered and seeds are now cold. The rate of treatment toxicity is very manageable. Like Dr. Weiss's slides showed that necrosis rate was almost 7%. So let's look at the design of these tiles. Well, I'll go to the next slide for this, but I do want to say that some of the challenges which are addressed with GammaTile is that we don't have a time delay. Targeting precision is good, and the radiation limits or personal exposure is literally minimal. So here's the design of GammaTile. So these are 4 seeds which are inside a bioresorbable membrane. The size of these tiles is 20 by 20 by 4 millimeters, where and the seeds are cesium. And I have one more. This one is a better schematics, and you can see the 2 seeds are almost 10 millimeter apart, and they are offset from the center. The seeds are not in the center of the tile. The side which faces the cavity, the seeds are 1 millimeter away from that boundary that faces the cavity, versus the side that actually sits on the operative bed. It's a 3 millimeter thick tile. So this simple design offset helps maintain the necrosis because the seeds have a natural distance away from the tissue and are not superbly like sitting right in the contact of the tissue. And usually the collagen dissolves itself within 4 to 6 months. So the spacing of these seeds is almost always maintained. Once again, one side of the tiles is textured, and this is the side that faces the operative bed, just so that the tiles don't move. And in terms of dosimetry, so this is cesium profile, and you can see that from let us say this is the implant place of the placement of the point dose, because it still follows the TG43. So within 2 millimeter in the tissue, the dose is almost 80 to 110 centigrade, and close to 5 millimeter from the point of implant, the dose falls off to 55 to 80 gray. And this is to our advantage, though the dose is going to be dependent upon what is the strength of the seed. So we usually order the seeds of 3.5U, which gives us this dose profile. Once again, the uniformity that you get with these sources is by placing the tiles really snug to each other. And this is a 3-tile straight configuration showing the 60 gray prescription line or the isodose line that we ideally try to cover the 5 millimeter of the operative bed or the tumor bed after the tumor has been resected. Looking at the workflow once again, patient selection. Right after that, the team lets us know that we need to go into gamma child planning. The pre-plan doesn't take much. Surgery is scheduled. The pre-plan earlier used to be a MIM-based procedure based on the surface area, and I'll show a slide on that also. But the main thing is to order your tiles on time and make an order which is at least 10% to 20% more tiles than needed, because once the surgery happens, you don't want to fall short of the tiles. And on the day of implant, the tumor is resected, and a biopsy is done to see whether it's tumor or necrosis. And once the biopsy or the frozen section is positive, the physicists take the tiles to the room, and the tiles are implanted. The most important thing would be post-op dosimetry, which is where the clinical dosimetry or your CTV coverage is then assessed from. So here's your pre-op planning. With gamma tiles, it is now a very, very simple process. Until last year, our method, which I have written here as previous method, used to be based on a MIM workflow where the radiation oncologist would delineate the resection cavity. We would give it a margin and then just look at the surface area by fitting an ellipsoid to that surface area and divide that with 4, which is the surface area of these tiles, and just rough estimate of our tiles. After thousands of patients, not thousands, like I think gamma tile has treated more than 1,700 patients now. They have a beautiful lookup table for us, which overestimates the tiles by 20%. And the good thing that the company does is it doesn't charge patients for that extra number of tiles. But all that the physicist has to do for clinical pre-planning now is look at the largest dimension and then correlate it with the clinical indication and decide the number of tiles and make the order on time. So that's a really good workflow improvement that happened this last year. And MCI was the one who validated this lookup table also. One more slide to show you how these sources work. They're isotropic sources, but the important thing that the prescription targets for brain mets are usually 60 gray to 5 millimeter depth from the tumor bed or resection cavity. And for meningiomas, that dose goes up to almost 80 grays. In terms of physics duties, they're no different from any other low dose rate brachytherapy procedure. So we do an on-site seed assay or a third-party assay. So even though the manufacturer gives us a calibration certificate, we look at that, we visually verify the calibration certificate, make sure that all the sources are within 10% of each other in their strength. But we also order a single seed from the same batch from which they have prepared our tiles from, and we use a dedicated calibrated well chamber and an electrometer that we keep only for gamma tiles, and we do our on-site assay there. Manufacturer also provides us an autoradiograph, and we read that, okay, we ordered 4 tiles. I should be seeing 4 radiographic marks on my autoradiograph. The physicist makes sure to print the patient discharge instructions and also prepares a radioisotope card for the permanent implant, which we give to the patient when we go for the post-surgery visit the next day. We also make sure in our workflow that CT and MRI appointments are done or scheduled for within 24 hours from the discharge, so that we don't have to call our patients back. So in terms of radiation safety of these sources, you need the physicist has to equip themselves with a survey meter for the pre and post patient surgery patient survey. We need to have a GM counter, which is, I feel like, traditionally being an LDR brachytherapist, I have a habit of carrying a GM counter, but these sources don't fall out or jump out of the tiles, but we still take them there for contamination check. Seed and tile count is done within the OR right after the tiles, right before the tiles are given. When they're given, we count the number of tiles, and as soon as the neurosurgeon implants the tiles in there, the radiation oncologist confirms the remaining tiles in the tray, and we then, our radiation safety process is done there. In terms of numbers or how safe these tiles are, the LDR implants. So healthcare workers receive a dose of 0.04 millisieverts, even less than that. This is less than 0.1% of the annual limit in the US, which is 50 millisievert for radiation workers. Patient caretakers at home will receive a dose of 0.91 millisievert, even if they are at 1 meter from the patient, which is less than 20% of the allowable annual limit for the patient release. And the neurosurgeons' ring badges, they usually record a dose of 0.23 or 0.5 millisieverts, which is less than 0.1% of the annual extremity doses. So the rule of thumb would be almost 1,000 implants would be needed for you to attend or stay right within 1 meter of that implant to receive any sort of come close to your annual limits. On the day of implant, I think we've already gone through this workflow. The tissue is sent for pathological confirmation of the disease. We, as medical physicists, are called 30 minutes prior to the needle, prior the tiles would be needed. Neurosurgeon places the gamma tiles while the radiation oncology keeps an eye that all the tiles are really abutting each other and not overlapping with each other. And right after the implant is done and the craniotomy is closed, the skull is closed, the medical physicist does the survey at the surface and at 1 meter from the site. Gamma tiles, so just wanted to show you how these applicators look. They're just these small tiles. They come in a steel tray. And when these trays are opened, there's a long forceps using which these are handled. The collagen is hydrated using sterile saline and sterile marker is used to make marks on the side that is going to line the cavity. Another picture of how we open our tiles, how we mark. These are taken from ROR. And pretty much this is how the procedure looks like. The radiation oncologist, the tiles are on a table, like a table that can be slid very close to the skull. And the radiation oncologist just picks up the tiles and starts lining them. And we just try to take the survey from 1 meter. So here's the clinical dosimetry post-op. So again, prescription is 60 grade to 5 millimeter depth of the resection cavity. Post-op CT is mandatory for visualizing the seeds. You don't see these seeds on MRI. Post-op MRI is mandatory for delineation of the resection cavity because you don't see that on CT. So MEM in the MEM, you fuse these two, delineate the resection cavity, identify the seeds. Dosimetry is going to be the same TG43 dosimetry, and you look at the D90 to resection cavity plus 5 mm, which is your CTV. OARs, we do, so brain, obviously, we do delineate skull and also scalp, and any other OAR nearby. One more view of how the post-implant dosimetry looks like on these patients. And here's a nice implant from a very dear friend of mine. They did like 11 tiles, and it took 4.5 minutes to implant these tiles on this patient. But you can see how beautifully the tiles can actually be seen on the CT, and how well these collagen tiles line up the cavity. And you can imagine the fact that this collagen is going to get absorbed in 4 to 6 months keeps the spacing of these seeds. So this is our very initial paper on our experience with the brain mets. We at MCI have primarily only treated brain mets and maybe very few recurrent GBM cases. But you can see that at 6 months, 12 months, and 18 months, we have excellent local control. And these patients did have a previous treatment on them, which was SRS. Okay, so this brings me to a paper that I just got my hands on, and I was really like, I loved reading this review paper. That so far, the LDR application, most of the time we talk about resection or the cavity applications, but what about unresected brain mets? Like, does LDR brachytherapy play a role there? And I wish I had more information to share here, but I'm going to share the resource and hopefully you guys can go back and read. So these are 8 studies. 7 of these are from Europe. And the review article just got published in like a couple of months ago. Though the primary, some of the authors here are also from MCI. Dr. Kotecha is one of our primary CNS radiation oncologists. So these studies is a review of brachytherapy as monotherapy, where no prior surgery is done on the tumors or is possible, but these tumors are accessible for brachytherapy seeds and strands. So they're not going to go anywhere, I feel, as long as we can work on taking care of the necrosis. So at this point of time, there's no grade 3-4 acute toxicities reported from this paper. Low morbidity and favorable outcomes on these patients who had who had surgery as no option for them, but LDR brachytherapy became as the main option. The main point here is that even that the procedure of implanting seeds and maintaining the treatment plan with the strands is considered a very, very complex procedure. This brings me to my questions now. My first question is, which of the following radioisotopes offers faster dose delivery and lower long-term toxicity risk in modern LDR intracranial brachytherapy compared to iodine?
Well, people are answering. I'm trying to imagine how the procedure would be done for unresected tumors. Is the tile placed around the tumor?
It's not it's actually, if I go back to the slide, this one is actually iodine 125 seeds and strands brachytherapy. So this is the tiles do not have an application there for now. So that's why I wanted to include the slide. It's not done very heavily here in the US, but in Europe, these 7 out of the 8 studies here are from Europe, and the only one center that's from US is like a really old data. It's not very new data. But these are seeds and strands brachytherapy with a very specialized approach.
Got it. And they are placed around the tumor?
Inside the tumor.
Inside. But
Yeah.
would that be a risk of seeding, for example?
I
For
feel like I need to read the paper too. I'm just so sorry.
Yeah, I mean, like the leptomeningeal disease is associated with any sort of tumor resection. I don't know that anyone has looked at like specifically with a gamma tile approach, but you know, a craniotomy is a craniotomy, whether you resect it and then do the treatment, you know, a few days later or not. I don't know that I would expect a big difference. I guess maybe one is that sometimes they will treat the tract as well as part of like the SRS volume, which in this case you wouldn't be doing. But I can't really say we've seen that here.
Got it. Okay. So we have 87% answering. So I'm ending the poll.
Okay, so I can see that people are divided between cesium and iridium. So iridium is more of a high dose rate brachytherapy source, and the right answer here is cesium. Palladium is the correct answer also. I was actually thinking to take palladium away from there to not confuse people. So it's a bit surprising for me that I was thinking cesium and palladium will go 50-50. But iridium, yes, so iridium will be a high dose rate source and will not be permanently implanted. And I did not find much literature into the use of iridium, and our talk was more on low dose rate brachytherapy in the brain, which is where more potential of brachytherapy has been proven so far historically also. So cesium is the correct answer, and the new design of the tiles and the higher fall off rate or the faster dose deposition is what helps cause less toxicity. So the second question I have is with respect to the prescription. At what depth from the resection cavity is dose prescribed to in an intraoperative LDR brain brachytherapy? At the surface of resection cavity, at 2 millimeter from the cavity, at 5 millimeter or 5 cm?
I think both of you covered this very well, so people should answer it correctly. Okay. We have 82% answering, ending the poll, sharing results. So 59% answered 5 millimeters, option C.
So in terms of where the dose is prescribed, 5 millimeter from the resection cavity is the right answer. Though in terms of reporting, like where do we report the dose? Yes, we report the dose at the surface of the cavity, and we report it at 2 millimeter also. But the prescription or the coverage is assessed by how well is the resection cavity plus 5 millimeter of the tissue from the surface is covered. So
excellent. Thank you.
So that brings me to my summary slide. So brain low dose rate brachytherapy certainly has promising results. It has proven to have a good high rate of local control of the disease. It has a modest rate of surgical complications, has a low risk of radiation necrosis and irradiation settings. And in terms of improved tumor control, START is the acronym given to stereotactic ablative radiation therapy, where cesium tiles are used. And it's proven to show improved tumor control compared to initial courses of EBRT. And CERT is what was for the unresected tumors, the stereotactic interventional radiation therapy. I feel like brachytherapy physicists keep coming with new acronyms, but this is what you will be seeing in publications. So I wanted to share those here. So CERT is for the unresected tumors with iodine 125. That seems to hold promise for monotherapy, where surgical resection is going to be challenging. And LDR brachytherapy, yes, is an effective strategy for recurrent tumors and priority settings. And this is our center in Miami, and I'm happily sharing this picture of our guests from Ukraine before. And I wish that more of you can travel the world and more of you can have way more collaborations. And I love to put this quote in here. Thank you so much for giving us this opportunity. I'm really honored, and so is Yoni.
Thank you very much for great lectures, for very interesting topic, and we would like to open the floor for questions from the participants. You can type your questions in a chat, or you can turn on your microphone and ask directly.
Thank you so much. That was an excellent lecture, and I really love this quote. I will read it because it's so important. You cannot hope to build a better world without improving the individuals. To that end, each of us must work for his own improvement and at the same time share a general responsibility for all humanity, our particular duty being to aid those to whom we think we can be most useful. By Marie Curie. Thank you so much for putting in there. It's beautiful.
So while people are thinking about their question, I do have a question about the workflow. So I was interested in how a radiation oncologist is collaborating and with a neurosurgeon before the treatment is planned. In a follow-up period, also who is monitoring the patient, and yes, so that is a question for radiation oncologist.
Sure. So good question. So I think it can vary. I think in terms of, and I think this is related to the question that's posted in the chat about, how to convince a neurosurgeon. I think, most people that are working in a cancer hospital or they're working with a neurosurgeon, there's usually like either a tumor board meeting or even if it's just phone calls between you and the surgeon. And it's a very common thing where, you do some treatment and then later on the lesion is growing or this or that. And I think it's very common that you're not sure, is this a local progression or is this radiation necrosis? And so I think the two ways to sort of like a really good indication for it in terms of the pre-patient selection is, if there's any sort of uncertainty on the diagnosis where surgery is helpful for the pathological confirmation. We've had, a number of patients where it's radiation necrosis and then we don't proceed with the implanting of the tile, right? And so anywhere where there's that sort of like equipoise where you're not sure what the diagnosis is, this is a good technique. But also in areas where you may not have a full stereotactic radiosurgical program. So, if you don't have a linear accelerator based SRS, SRT setup, but you're seeing a lot of brain metastases, this is one way of getting very similar or better dosimetry compared to Gamma Knife or CyberKnife or a linear accelerator based without necessarily needing that full technology available because you just order the tiles and then you have the surgeon place them. In terms of the follow-up, at least here, we usually try to do them in a multidisciplinary clinic. So the surgeon and the radiation oncology may not be the surgeon. Sometimes it's like a neuro-oncologist, like a neurologist that specializes in brain mets. But usually it's in a multidisciplinary clinic where we'll see them with MRIs at least every 3 months for the first little while to evaluate basically post-resection and post-treatment, to make sure, because you can still, of course, get necrosis after this treatment as well. So that's usually how we do those follow-ups.
So, and also the tiles are ordered for the treatment, right? So, how quick is the order to implant time for the given treatment?
So our turnaround on the tiles is usually 4 days. Though the company says that they can provide the tiles within 2 days, but we have kept the minimum turnaround to 4 days. And that is for us to be able to look at the surface area and confirm everything from our end. Because once the tiles are here, you cannot delay a procedure. So because this is a multidisciplinary, in a multidisciplinary setting, so we have neurosurgery coordinators, we have radiation oncology coordinators, and then we have nursing. So we have to make sure that everybody is on the same page, including the patient. And there's not, the surgery has been confirmed. So once we know that the surgery is confirmed, and the MRI that we use for gamma tiles has to be less than 1 month old. So if the patient doesn't have an older and doesn't have an MRI within that time, then we have to call the patient. So from the company standpoint, they tell us that they can give us the tiles within 2 days, but we keep it in our benefit to confirm everything before we can even order the tiles. So we keep it to 4 to 5 days.
Yep, thank you. Marina, maybe you have a question?
Yeah, thank you so much. Thank you to Dr. Weiss and Vibha for your interesting and inspiring lecture, and I always appreciate the depth of your knowledge. And I have a few questions. First of all, is there any contraindication, maybe neurological, for providing brachytherapy, intracranial brachytherapy? Maybe a patient have, especially in case in radiation, maybe patients have currently some neurological problems, and it could stop to provide brachytherapy. And another question, maybe I'm confused, but as I understand that the seeds permanently stayed in the tumor cavity, and if it is it have some influence on next MRIs with artifacts with evaluating local control, or maybe I'm wrong with it?
Yeah, so in terms of so the bioresorbable, the half-life is 10 days. So, by 50 days there's really no radioactivity left. And then after the first couple MRIs, it should sort of normalize in terms of it being resorbed. I think, of course there can still be some uncertainty about what's necrosis versus progression. At least before the treatment that it definitely wasn't necrosis to start with, but then afterwards, it can be, then you have the same question maybe 6 months later, 1 year later, is it growing back after the gamma tile or is it necrosis? And usually it's necrosis because the local control rates are like really, really high. In terms of like the contraindications, so most of what we're doing is for like after there's been resection. So any surgical contraindication would then be a contraindication to this. So any area of the brain that's eloquent, so very adjacent to like the critical structures, the cranial nerves, the motor, or the sensory cortex, you would have a lot of caution. That being said, this isn't like mandatory. You can of course still do linear accelerator based stereotactic techniques in these areas. And so in the eloquent areas, even if you are expecting some sort of nerve damage, like sometimes we are even blinding patients if that's the only way to cure them of their disease, right? But that generally wouldn't be done with the LDR technique. Mind you, people will do LDR for like a uveal melanoma too, for example, right? And so in that sense, we're sometimes even implanting things in an area that we know someone will have a risk of a nerve injury. So I don't know that there's any strict contraindications other than, the surgeons like this isn't an area that I wouldn't want to resect. It's better to just do an external beam technique, basically.
Okay, thank you so much, and it was a pleasure to see you again. Thank you.
Likewise.
And in terms of your second question, Mary, the seeds don't cause any artifact in the MRIs. And in fact, we've had patients where we see a lot of recurrent patients. We are in Florida, a lot of older population. Our patients come for like 5, 6 retreatments. That's how I feel. So I've seen these seeds clustered after 8 or 9 months at the end of the cavity when the collagen is fully gone. But on the MRI at the max, it doesn't cause an artifact, but you would actually see the signal deficit there because there's no fluid where the seeds are. So you would see a black spot, and when you correlate it with the CT, all the seeds are clustered there. So it doesn't cause any artifact in the MRI.
Thank you. And also the question on that side, so what is if after the post scan showed that there was an insufficient number of the tiles, what would be the course of action?
So for this one, for any low dose rate brachytherapy, permanent brachytherapy procedure, this would be a scenario anyone would fear. What if I'm implanting less seeds? What if I'm implanting, I don't see the coverage? So I would say that these are permanent implants. You're not going to go there and implant another seed saying that one seed was less. So the way treatment planning is done, even for prostate treatment planning, you go a little bit over when it's the LDR treatment plans. And like I said, in terms of seed order, also, you order 10 to 20% seeds more. So these tiles, when the treatment plan is made, the whole surgical cavity is lined with the tiles. And we order 20% tiles more. And just it's not I would say the way the dosimetry works after the whole tumor bed has been lined and these sources maintain their position, you don't get into that scenario. And the pre-planning is done in a manner. The technique has been developed in a manner to avoid this scenario. Yoni,
Yep.
would you like to add something to this? Like in a low dose rate implant, I've never come into a situation where we've had a post-op dosimetry which is exceedingly insufficient.
Yeah, I mean, I agree. I think it's really up to the group expertise to sort of ensure that this is ordered appropriately. Like Dr. Chaswal mentioned, ordering 10 to 20% more, and then that should be fine. I think it's also to the point of making sure you have an up-to-date MRI within as close as possible, because if you are then resecting it and it's much bigger, then that's really the main time you would maybe run into issues. That, I think if you were to start the surgery and then be like, oh wow, this is clearly going to be an insufficient number of tiles, they can just resect it and then close them, and then you could do a different form of radiation. Practically speaking, we haven't really done that because the turnaround time is definitely sort of fast enough. But that's, a theoretical consideration.
And one thing you have to think about is that the full clinical dosimetry here is post-op dosimetry. So think of a scenario where a pre-op cavity was estimated, like the doctor thought that I'm going to remove this much of tumor, but he was not able to remove that much tumor, and there is a residual tumor there. We are not going to be using the estimated cavity to do our post-op dosimetry. We are going to be still doing the contouring again. The real resection cavity will be contoured, which is where all the tiles have already lined up. So the real resection cavity always gets the dose that it has been intended for. But if there's a residual tumor, like Yoni said, you might have to then think of another course of radiation because the tumor was not surgically possible to remove. And that changed how your treatment plan would have looked like. So
Yep. Thank you. Also from the chat from Oleg Ovsienko, hi Yoni and Vibha, I'm glad to see you again and more interesting information. Thank you for excellent presentations. And also from the chat, the question that in Miami Cancer Institute you have protons, you have brachy LDR, you have gamma knife and cyber knife. So how do you select technology for brain mets?
Yeah, so that's a good question. I would say that for like upfront brain metastases that they've never been irradiated before, our preference is generally to treat them with a gamma knife machine. Part of it is also related to, you have a certain number of machines in your department, and if you, in theory, you could treat everything on the same linear accelerator, but then we'll be treating 24 hours of the day. And so we happen to have the gamma knife machine, and so that's what we're using for most of the upfront brain metastases. We actually, for that reason, are removing our cyber knife, so we'll no longer have that technology. We'll just have a regular LINAC in that room moving forward. The protons, there are some interesting uses for that. And so this is getting, a little bit off of the main topic, but one of the techniques that we're doing some research in is called pulsed reduced dose rate radiation. So that's, you may recall from radiobiology lectures that one of the things that you can help to prevent late effects is actually reducing the dose rate of the radiation. And so when we're reirradiating some of these sort of larger, like meningioma or glioblastoma, that are big reirradiation volumes, we've sometimes been using these protons to minimize the integral dose, to minimize sort of how much brain is being reirradiated, and also to sort of reduce the dose rate in the theory that maybe this will reduce the complications. But that's still sort of a very ongoing area of study. So just to sort of summarize, most of the time, gamma knife, I think when we're having reirradiation of small areas, we're either doing the gamma tile or gamma knife, and then for sort of big volumes, you'll always be doing sort of regular linear accelerator based, or in some situations, proton based, with or without a reduction in the dose rate.
Thank you for
Thank
that
you.
answer. I missed ZAP actually too, right?
Yeah,
You
also
have ZAP.
Zapex. That's a good question. I think like the Zapex probably is part of the reason why we're getting rid of the CyberKnife too. There's, it's another sort of stereotactic system that I think is similar in terms of the distribution to the CyberKnife. Though I will say, like, we have it. Um, I don't know that. I don't know if Dr. Chaswal can comment to like the number of patients we've treated on that system in the last, year or since we've had it. It hasn't been as high of a throughput. I would say it's not like a throughput machine.
I think
But
ZAP treatment planning, when you are used to gamma knife treatment planning, it's very difficult to then go down to ZAP and then trust it for doing what it's showing it's doing. We have treated more than 25 patients on ZAP, and these are mostly our patients. We are sharing the workload from Gamma Knife. The treatment planning takes, it's much simpler than Gamma Knife treatment planning. So initially we would triage patients with a lot of skepticism, but we've done a lot of QA there, and ZAP has good publications also. So we are building our trust with the machine as such. But it's now that, CyberKnife is going to go away because ZAP is taking more like some of our patients. It also fits smaller patients. ZAP cannot have big patients in there. The bore is really small. So that's another limitation of that machine. So, but we've treated almost 20 patients so far on that machine. So gaining more experience with it.
It's amazing. I think your center should publish on it because you have all the technologies available. You should do a comparative study.
Thank you for both for interesting lectures. A question from Laisa Mitsak. What is the cost of gamma tile for brachy for one patient? and how costly it is comparing maybe to other
But are you
techniques.
familiar with like the cost of the tiles themselves? Because I think for the like whole procedure, the better person to answer would probably be some of the German centers that do this. And I, as mentioned, like I trained in and did everything in Canada. So to me, I've been now here 4 years in the United States, and to me, the billing and pricing of everything is absolutely insane and like sort of a bit of a black box. So I would say it's probably some obscene number, but I think if you were to try to anchor it in reality, the like the fixed cost is the actual tiles, which must have some sort of price tag. I just don't know off the top of my head. I don't know if you do, Vibha.
Yeah, I don't have the right answer to this question, but in terms of just the tile order, it goes from anywhere like 20K to most of our tiles are like 3 to 4K, 4 tiles order. So like I think 10K, 20K per tile. It's a pretty expensive treatment here. But like Yoni is saying,
Yeah,
most of
but
this is like an
yeah.
inflated
From a
price.
health economics perspective, a linear accelerator-based stereotactic solution would be the cheapest because, and I can say from Canadian data that a five fraction, like sort of a SRT course, would be in Canadian system about $5,000.
On this subject, a comment from Natalia that it might be good if manufacturer included marks where the seeds are placed. So for dosimetry planning and for if you need to cut the tile, so you can cut that
So,
knowing that where seeds are.
so the tiles can only be cut in half on like oh, they can only be cut once and they can only be cut in half. That's from the manufacturer's recommendation. And somehow my picture doesn't show it very well here, but the tiles actually have very small indentations where they can be cut and they cut very easily. Um, you don't have to work very hard to cut these tiles. I'm surprised the indentation is not shown, but they can only be cut in the half and they do have the mark there.
Yeah, thank you. Thank you for those answers, and thank you for the cost question. I think it's very relevant for Ukraine, and we will have to find the answer to this.
I will get back to you. I'll write to our representative and I'll get back to you, Natalie, on that
Yeah, that would be great.
on that question and you can share.
Yeah, thank you so much. Thank you again to our speakers. It was an excellent lecture, very interesting, and a lot of things to think about. And I would like to take a screenshot of our photo, please, if you can turn on your videos. I know it's late in Ukraine, but it would be nice to see your faces. I have a picture with our speakers. A lot of people are missing electricity because of missile attacks, so you could see dark houses somewhere in Ukraine. Flashlights. But they are watching your lecture, see? That's a
No, this is
dedication. This is
this
a
is amazing.
dedication. Yeah, this is
We're
amazing.
very honored by the opportunity and also looking at the curiosity and the questions. I would say this was definitely one of the richest experiences I've had in a virtual lecture.
Oh,
Very,
excellent.
very good students. Pat
Oh,
on the back
thank
to
you.
each one of you.
Thank you. So I'll take a photo. Please smile. Okay, excellent. Thank you. I'll share the photo. Thank you again. Thank you,
Thanks for
everyone.
having us. Our hearts are with you. Slava Ukraini.
Героям
Героям
слава.
слава. Thank you very much.
Bye.